In this short presentation for AJNR Trainees Corner, we are going to talk about how to report Alzheimer's disease baseline and post-treatment MRI for ARIA, what imaging features to look for, and what details to include in your reports. My name is Maryam Vejdani Jahrumi. I am a junior editorial board member of the AJNR, and I will be presenting this talk in collaboration with my colleagues at Harvard Medical School, Massachusetts General Hospital Radiology Department, Dr. Sarah Brodke, Dr. Jeremy Ford, and Dr. Javier Romero. Let's go ahead and get started. Here are our disclosures. As we know, Alzheimer's disease is a neurodegenerative condition causing cognitive impairment affecting the aging population worldwide. Studies have predicted a substantial increase in number of patients with Alzheimer's disease from 57 million patients in 2019 to 153 million patients in 2050. The cost burden of Alzheimer's disease in the US in 2020 was estimated at $300 billion. FDA has recently approved anti-amyloid beta therapies such as lecanemab to slow down or stop the progression of Alzheimer's disease. Patients will receive baseline MRI to evaluate eligibility for treatment and regular post-treatment follow-up MRIs to assess for ARIA. Amyloid-related imaging abnormalities, also known as ARIA, are a spectrum of MRI findings in patients receiving anti-amyloid beta therapies, which we will talk about later in this presentation. Here is the recommended follow-up MRI schedule by Alzheimer's Organization for patients being considered for anti-amyloid beta therapies. Baseline MRI should be done within 1 year prior to initiation of treatment. Infusions are scheduled every 2 weeks, and MRI follow-up imaging is done prior to the 5th infusion, 7th infusion, and the 14th infusion. At any point during treatment, if the patient develops symptoms suggestive of ARIA, an MRI will be performed. Here is the MRI protocol and minimum required sequences for detecting ARIA. It is better to perform the scan on a 3 Tesla scanner and with the same type of sequences and protocol for baseline and subsequent follow-ups to be able to compare the changes reliably. GRE and or SWI sequences for ARIA-H, T2 FLAIR sequence for ARIA-E, and DWI sequence to rule out other etiologies. ARIA signal abnormalities are divided into 2 categories, ARIA-E and ARIA-H. E in ARIA-E stands for edema and effusion that is from leakage of proteinaceous fluid. H in ARIA-H refers to hemorrhage, and it includes macrohemorrhages within the parenchyma or superficial siderosis and is caused by leakage of small amounts of iron-containing blood products. There are 3 main risk factors that could prompt the patients to develop ARIA. They include presence of pre-treatment microhemorrhages or superficial siderosis, ApoE4 genotype carrier status, and exposure to anti-amyloid beta antibody and treatment dosage. Here are the 2 patterns of ARIA-E that can happen. The left-sided image shows the parenchymal edema at the left parieto-occipital region on this FLAIR sequence. The right-sided image shows an example of effusion at the leptomeningeal region in several sulci of the right temporo-occipital lobe. On this slide, you can see the changes that we see in ARIA-H. The left image shows GRE sequence with punctate susceptibility foci representing microhemorrhages at the left parietal lobe. The right image shows a small focus of leptomeningeal susceptibility artifact at the left frontal region representing superficial siderosis. Here you can see additional examples of parenchymal microhemorrhages on GRE sequence shown on this slide. In this slide, you can see an example of post-treatment development of superficial siderosis at the left frontal sulci. Now we can discuss the important details that need to be included into the baseline scan MRI report. Our report needs to present the number of microhemorrhages based on GRE and or SWI sequences. We need to list up to 5 microhemorrhages. It would be beneficial to mark the images or put image numbers in the report. Presence or absence of superficial siderosis needs to be mentioned. It is important to note that recommendations and guidelines for eligibility for treatment are based on GRE sequence for number of microhemorrhages. Since SWI sequence has generally higher sensitivity and resolution for detecting microhemorrhages, the recommended thresholds could be different for SWI sequence, and this is a field of ongoing research at our institution. In this slide, you can see an example of the dictation macro template we use at our institution for reporting baseline MRI. This can be added to the report in the findings section. When reporting white matter disease and baseline MRIs, Fazekas scores are used from 0 to 3. Score 0 means that there is no flare hyperintense signal abnormality within the periventricular or subcortical white matter. Score 1 indicates a few scattered foci of flare signal abnormalities. Fazekas 2 indicates these signal abnormalities are starting to have patchy appearance. And Fazekas 3 indicates severe white matter disease with substantial confluence signal abnormalities. In this slide, you can see the details to be included in the report on post-treatment scans. They include date of the baseline scan, number of new microhemorrhages, new superficial siderosis, new brain edema and or effusion, as well as severity scales of ARIA E and H. This slide shows an example of dictation macro that we use for post-treatment MRI studies for ARIA assessment. This can be added to the findings section of the report. This table includes the details of ARIA E and H and how to categorize ARIA in mild, moderate, and severe categories. It also includes superficial siderosis and how to categorize that for ARIA H scaling. It seems that number 5 and 10 for both ARIA E and H categories are helpful numbers to remember for the threshold of mild and moderate changes as shown on this table. This slide shows examples of mild, moderate, and severe categories for ARIA E and ARIA H severity scales. If the area of flare signal abnormality and hyperintensities is less than 5 cm, it is considered mild. If it is between 5 to 10 cm, it is considered moderate. If there are more than one site of involvement less than 10 cm, it is considered moderate. Severe category is when you have flare signal abnormalities spanning more than 10 cm in extent. For ARIA H, new microbleed foci less than 5 is considered mild, between 5 to 9 foci of microbleeds considered moderate, and 10 or more than 10 foci are considered severe ARIA H. In this slide, you can see an example of post-treatment ARIA E development within the right parietal white matter and how we measure the extent of involvement considering the underlying white matter changes. Measurement of extent of involvement is challenging and is under investigation for how to report it accurately, including 2D and 3D or volumetric measurements. We hope that you find this short presentation helpful for reporting of ARIA studies. We try to give a summarized overview of how to report these studies. Obviously, all details, including interpretation pitfalls and differential diagnosis, could not be covered in this brief presentation. Please refer to publications, references, and additional papers on this topic for further recommendations and specifications. Thank you.